So I just want to say thanks for having me. It's been a real pleasure to come visit over the years. I think this is either my fourth or fifth trip down, and obviously a lot of that comes from my close connection with Harold, but I've gotten to know quite a few of the residents and faculty over the years, and it's just been a real pleasure. I consider UTMB kind of my second ENT home, which is a nice thing to have. We're probably the only sister society relationship I bet in Otolaryngology. And we do have a lot of connections, between the programs. Myself and Harold, of course. I don't know if you know, he was a multi-award winning resident at UNC, as you can see there with those trophies. He developed a system for locking the residence room when things got a little too crazy. Adapted from, what's the movie called?
War Games.
War Games, okay, very old one. And of course, it's a pleasure to participate in the Bailey Society. Obviously, there's a whole generation of people that learned from Dr. Bailey, and were introduced to him as interns by carrying that big heavy book, 2 books around. That's when it kind of all started. And there's even deeper connections, as Dr. Pillsbury was our chairman for many years, was involved in that book as well. And you can see me carrying around my first set of Baileys there. Luckily, this eventually ended up on CD-ROM for everybody, and I'm sure on the internet by now. That's what, for the residents, that's what a CD-ROM looks like. And there's some other connections between our 2 programs as well, and that includes Brent's trips to Vietnam, which both Harold and Dr. Bailey participated in. So it's been fun to kind of get to hear about him and get to know him a little bit more on a personal level too. So thank you very much for having me. I wanted to start off with a few quotes. When Harold told me I'd be invited down to give a talk, I found this quote and really wanted to include it in my talk. You make the living by what you get, you make the life by what you give. And I thought that was awesome. Winston Churchill, I can't wait. And then as I was putting my talk together, all I found was that this is falsely attributed to Winston Churchill and is probably unknown, but I still think it's a great quote. And then here's a quote we do know from Dr. Bailey: "May we always keep the needs of our patients foremost in our minds and in our hearts as we study, learn, and practice the science and art of medicine." So that's a really nice quote. And I think it kind of addresses, sort of why we're in this. Why are we in medicine? Some of you might recognize Simon Sinek there in the center, and he's sort of well known for thinking about, sort of the why it is we do things, sort of your core values and beliefs, and what drives you to do what we're doing. I mean, otolaryngology is a little bit of the how, but the why is a little bit more why we're in medicine. And everybody has their own reasons, maybe participate in medical mission trips or research. Obviously most of us are in this for noble reasons: taking care of patients, relieving pain and suffering, helping our fellow man. This is my dad down in the lower left corner. I thought it'd be fun to work him in, but he was a flight surgeon in the Royal Canadian Air Force back in World War II, and a good inspiration. I know some of the reasons I'm not in this. It's not for constant epic clicking, figuring out the many categories of RVUs, and things like that, which kind of drive us nuts. In fact, a recent paper found that every hour of patient care we add on is currently adding about, in the outpatient setting, is currently adding on about 2 hours of additional, computer, EMR, and office time. So that's something we certainly need to keep track of. So that's kind of sort of the stuff we have to do. Not so inspiring, but so I sort of looked in the bulletin for a little bit more inspiration as to why I'm in this. And it looks exciting, the bulletin. Great cover. So I opened it up, and so I just read a little. Unlike the MU program, ECs can receive partial credit for the ACI portion of the MIPS composite score using a qualified registry EHR QD-CR attestation or CMS web interface to report ACI measures. Well, that wasn't too inspiring. So more of the stuff that we have to do, but not necessarily why we're doing it. Hopefully everyone did get a chance to capitalize on whatever it is they're talking about. But of course, the question is, does ENT help us sort of achieve those things that we're in medicine for? And I would argue that it is actually a great specialty for that. And I've never regretted my choice to be an ENT. I think it's a fantastic and unique field for allowing for that, and really an important field in innovation in medicine. It brings to mind, like, what number of ENT people are sort of happy with their choice of ENT? I don't know, we can do a quick poll here. How many people feel like ENT was a good choice and they're happy they're in ENT? Okay, I think it's even higher than the average here. This is a recent survey this year of over 19,000 doctors, and ENT does pretty well. About 88% of providers surveyed, felt that they would choose the specialty again. So I think that bodes well for our future and the residents' future. And I think, as I said, I think ENT is an excellent choice and uniquely suited to giving back and making contributions. And in fact, I think there are certain unique aspects of ENT that make it the natural innovation specialty. And I made up my own quote here. There's something about ENT that makes it one of the strongest fields in medicine for innovation. So I'm going to keep quoting myself. And here you can see, I don't know if you can tell where I am here, but I'm at UTMB a couple of years back and trying on some Google Glasses, and one of you all have given a talk on some of the applications of Google Glass and some of the cool new applications in medicine and as they relate to ENT. So I've been inspired by you guys here as well. Let's talk just a little bit about the history of our specialty. Specialization within medicine tends to follow the creation of knowledge, the growth of science, and the development of new technologies, as we know. In the 1850s, the early ophthalmoscope and otoscopes were being developed, and by the late 1800s, the American Academy of Ophthalmology and Otolaryngology was formed. And pretty amazing. Just a year later, the Triologic Society was formed, which we all, many of us, still participate in, and it's such an important organization in our field. A couple of sort of smaller societies got together and formed the Triologic Society that long ago. In 1924, the American Board of Otolaryngology was formally organized, and as Brian talked a little bit about, this is around the time of the Flexner Report, which is well covered in the book he mentioned, The Transformation of American Medicine. And it's a time, maybe sort of a Wild West-ish time, when the medical education, the profession itself was sort of like basically being organized, and there was really no subspecialties, and so we were one of the earliest and first subspecialties in a sense. At first kind of lumped and combined with ophthalmology, but before long on our own. Now, the origins of what we do clinically are basically ancient. I mean, there are reports of tracheotomy, from ancient Egyptian times and other procedures that we do, and so in a sense we're part of a much longer tradition. In the 19th century, clinically, you'll recognize some of these names, but a lot of the innovations and new discoveries in ENT were happening, and so whether it's Meniere or Weber or Rene or Schwartzy, all these eponyms you'll recognize, Caldwell and Luck, these first discoveries were being made. Thomas Buchanan at that time used artificial light to inspect the eardrum with a device he called the Inspector Oris. Joseph Toynbee was an early practitioner of myringotomy and mastoid surgery, and the first to describe the Valsalva maneuver. And I found it interesting that he actually died trying it at age 51 while inhaling hydrocyanic acid and chloroform, trying to cure his own tinnitus. So you have to be careful knowing what you discover sometimes, I guess. Robert Barony was known for calorics and rotational chair testing, and one of our field that won a Nobel Prize in 1915, for which we should all be proud. In the 20th century, I think we could consider that the golden age of otolaryngology. This is where allergy treatments are being better understood and employed. Endoscopic surgery is coming along, dramatically changing just about everything, especially rhinology and skull-based surgery. We see regional and free tissue microvascular reconstruction, the application of lasers, hearing aids, and of course cochlear implants, still probably one of the highest levels of technology that's implanted routinely. Image-guided surgery and surgical assist devices like the Da Vinci robot, all coming along in the 20th century. In the grand scheme of things, not really that long ago, that all these developments were made. And it's kind of fun to be a part of that, time. thought I'd throw in this quote quick. I'll read it quickly, but as I was learning some of this history of our field, I read this from a physician in Crete, Dr. Helidonis, and it's amazing how accurately he just sort of nailed the upcoming future. The practice of otolaryngology in the future will be different, for sure. A number of interventions will be done through blood vessels where implants administer drugs for destroying tumors. Other implanted devices will restore the function of different organs. At the same time, imaging in the form of virtual reality will allow the surgeon to better perform different procedures, and the same method will also be used for training and reversal surgery. In laser surgery, the introduction of new laser systems will allow for more precise surgery, dry and free of complications. Robotic surgery will have also its place when the surgeon wants to perform minute procedures. So I think he nailed like 3 or 4 really key things a little bit ahead of his time. Not that long ago, but still, 1993. And so there are so many leaders in our field when it comes to innovation. We can talk about Bill House. We can talk about many of the others from the list on the previous slide. But I thought I'd focus a little bit on Chevalier Jackson. One of my favorites, but certainly one of Dr. Pine's favorites. And I think he's a good example of how innovation comes about. How much is due to the person himself and their drive and their dedication to their why, sort of our underlying core values, and how much of it has to do with others. I mean, these things are rarely done alone. A lot of it's incremental, and a lot of it has to do with the time and the age that you're in. And so we'll talk a little bit about him. Does anyone have a guess what this boy is suffering from? Other than Dr. Pine. Does anyone have a guess? All right, we'll go with Dr. Pine.
Retained foreign body.
That's right. So this boy is from mid-19th century, and I mean, he spent weeks to months, and I actually don't know the answer as to whether he survived or not. But what he's suffering from is something as simple as an esophageal coin. And it shows you kind of the change over a 100-year time frame in our field and our specialty. Around that time, a review by Dr. Edelman of 314 cases of patients with untreated esophageal foreign body found that survival was rare. And 109 of the patients from that group actually died of perforations of the heart, the aorta, or the great vessels, pretty dramatic ending as these coins or other retained foreign bodies migrated. So survival was really rare at this point in time. Few survived, and for those that underwent open surgery to remove foreign bodies, few of those survived. And so some innovation in this area obviously was needed, and this is the kind of picture that was driving the otolaryngologists of the time to do something different. So Dr. Jackson was born in Pittsburgh, 1865, right at the end of the Civil War. He attended Western University of Pennsylvania, which became University of Pittsburgh eventually, or combined to become University of Pittsburgh. And like doctors did in the day, with limited subspecialty training, he did an apprenticeship with Dr. Gilmore Foster. He had to help fund his training, and so he worked as an artist, as a fisherman, as a book agent, in summers and in between training. And ultimately, he went to medical school at Jefferson Medical College in Philadelphia and graduated in 1885. And this, just to put it in a time frame, this was kind of like the dawn of aseptic technique, where people were kind of realizing some things about sterility. He developed an interest in the nose and throat, and this was in a time when subspecialization was rarer. And he had come across some of the writings and books by a budding laryngologist, or someone with an interest in laryngology in London, named Sir Morrell Mackenzie. And he had written extensively on laryngeal pathologies. He had a well-known 3-volume essay. He was known for founding the Hospital for Diseases of the Throat, eventually in London. And there's a very interesting story about him in particular, as he was involved in treating the German Crown Prince Frederick. So I'll digress for a second because it's kind of an interesting story. But the Crown Prince in Germany had come down with some chronic hoarseness over several months, and he was in line to become the new Kaiser of Germany. And his princess his wife, was English, and she had sought the advice of Queen Victoria, and Queen Victoria had known about Dr. Mackenzie's reputation that was growing in regard to voice problems and hoarseness, and it's almost too early to call it laryngology, right? But so he traveled to Germany to help the Crown Prince, and he did a couple of biopsies, and these were read by none other than Virchow himself, and they were read as benign. And so, and he had a great relationship with the Crown Prince, and he eventually traveled back to England, returned to England, and the Crown Prince went on to become the Kaiser, but he was ill throughout his tenure, and what ultimately became apparent is that this wasn't benign, and that he had a laryngeal cancer. And so this actually, in the press was a big deal and led to some tension between Great Britain, between England and Germany at the time, and this sort of the notion that they had failed to diagnose this cancer, despite obvious limitations and challenges at the time that we don't really face. And people have even wondered, if this could have had some impact on the beginning of World War I. As the Crown Prince, now Kaiser, died, his son Wilhelm II took over as the new Kaiser, and was a big part of the early origins of that conflict. So I think the lesson there is be extremely careful when you're biopsying something. You never know just how important that might be. And so Chevalier Jackson went to London the year before this all happened, and studied with Dr. Mackenzie. And then he returned to Pittsburgh in 1887. During his first year was when this controversy in Europe was going on, but he began his practice in Pittsburgh, and he had a great interest in the nose and throat, and started to investigate better techniques for dealing with foreign bodies and other issues. Eventually he returned to Philadelphia, where he became the chair of laryngology, and ultimately they created a new department for him called the Department of Bronchoscopy and Esophagoscopy. And it shows you how changes in our field really mirror advances in technology. So based on these new technologies, they created a department for him. He had a reputation for laryngology and treatment of aerodigestive foreign bodies and also caustic ingestions. He campaigned for labels on all poisonous or corrosive substances, resulting in the Federal Caustic Poison Act of 1927. And is credited with the development of the rigid esophagoscope, the addition of a light carrier to endoscopic instruments, and really the inventor of the lighted laryngoscope, which our anesthesiologists continue to use today. Here's a picture of him. His collection of over 2,000 swallowed objects actually was just formed into an exhibit this year at the Mutter Museum in Philadelphia. So if you get a chance this year, or you're in Philadelphia, maybe check it out. He was an avid collector and of these foreign bodies. And in fact, there's one story about how a father wanted this coin that he had removed back, a quarter. And so this poor child had been kind of beaten on for swallowing a quarter in the first place. And then when they didn't get the quarter back, he got beaten on again by his father, and his arm broken. And the father came to actually threaten Dr. Jackson and say he was going to kill him. So eventually Dr. Jackson gave him a $50 and he went away. But he still didn't give him a quarter. And I assume it's in that collection, so maybe you can go see it. But, so that's probably the first foreign body board. I think probably most departments have had one at some point or maintain one. Here's ours at UNC. So, and it's a real tour through history to look at a foreign body board, to see the things that were once common foreign bodies, little toys, safety pins obviously fill this left side of the foreign body board and then disappear as diaper technology improved, and among other things. And one of our great nurses, Elaine, there at the foreign body board at UNC. And I like to think as pediatric otolaryngologists, many of us have what I'll call a Chevalier Jackson moment. When you get that one foreign body that's like quite scary, and reminds you, just sort of how dangerous these things can be, and not to take for granted kind of the technology that we're blessed with now. But this was mine. Dr. Brent Sr. called me, 6 a.m. one morning and said, I'm on call, but this child just rolled in. I was wondering if you could take care of him, and I said, sure. He said, there's a safety pin. So right then, you think, which way is it? Is it up, or is it facing down? That would be the better orientation, that upper corner, but this big picture was what we found. And so, you go through a thought process of just how are we going to remove this, And I can remember it created like a little bit of a stir, so I'm in the OR finally. I'm basically just going to, start this one myself. But obviously I had a lot of help from our great residents too. And people were yelling at me, you got to close it first, close it. I'm like, okay, yes, I don't. And then there's other people say, you got to cut it in pieces, then you'll be able to get it out of there. And others recommended pushing it into the stomach and then inverting it and pulling it out. Maybe that would be a better solution. And, I'll just say, I looked down there was a lot of clot, so that was the first thing to deal with, some bleeding and clot that had come from this sharp, pointed object in the esophagus. But in the end, what I did was just grab the pointy part and pull it into my esophagus scope, and that allowed me to remove it. So I don't know if that's the recommended way or the best way, but that's how I dealt with my Chevalier Jackson moment, and I haven't had any other safety pins since, so thank goodness. Let's think just a little bit about, what are the key elements of a modern, endoscope? You still really think about what you're blessed with, but, until you think back to what they were dealing with in the mid-19th century. But you need some sort of viewing tube, right, to look down the esophagus scope. It has to deal with sort of a circuitous path through the body, and a lot of the early people working on this, consulted sword swallowers just to see, like, how do you get that thing down there and around these corners and bends and things like that? So they were some of the early practice patients and consultants. But you need some type of viewing tube. You need a light source. Anesthesia was just, coming into its own in the late 1880s and early 1900s. And in the modern sense, we benefit from lenses and prisms that let us focus light, let us have a better field of view, and different angles of view as well. When it comes to light sources, the early light sources were candles, essentially, or sunlight. And as the pioneers of endoscopy developed better light sources, they talked about finally being free of the time of day or the season or the weather even affecting their ability to do an endoscopy. Finally they didn't have to worry about that stuff, like they couldn't do any endoscopies because it was winter, and there's no sunlight. So anyway, Philip Pizzini is credited as probably the founder of laryngoscopy, and that's because he developed this device, in the black and white picture there. Essentially, it's a device with a candle in it that helped to focus light a little bit, and he developed a number of attachments. And the reason he's known as ENT is some of these attachments were designed for sort of peering, within the mouth and hopefully the larynx and sort of the upper aerodigestive tract. Turk, who followed him, described using sunlight, of course, and Johann Zermatt is credited, a Czech doctor, with the first use of an artificial light source, which he described as a pump lamp with a double wick. He was also the first to visualize the larynx in a living patient, so a good accomplishment, and he photographed his own larynx. This was actually a remarkable accomplishment when you think how important, photography is in endoscopy and just medical imaging in general these days, and that the first photograph was only taken in about 1837, and so quite an accomplishment actually. When you think about the time these people were operating in, electromagnetism, was sort of a new area of discovery, leading to the development of the electric motor, the wireless telegraphy, which sort of precedes our modern radio. And there were surgeons noticing this interest in electricity, the new technology of the time. And so Dr. Hayter is actually a dentist that first used harnessed electricity for use as electric cautery. And Drs. Bruck and Mikulicz eventually talked about using galvanized platinum wire to produce light for distal use, not proximal, but in the body to help guide endoscopies. And so basically they're heating up wire with batteries. There's nowhere to plug in anything yet. That didn't really come along commonly until, I think they say in 1925, half of the households had electricity, but it gives you a sense. So they're using batteries and they're heating up wires and they're glowing, you know. So there's some light source, but you might not just want to stick it down into the esophagus. But really ingenious, they created a glass enclosure for their glowing wire and a separate chamber through which water circulated to cool this glowing hot wire and allowed for a more practical and usable distal light source. And so you can see there's a lot of work in endoscopy preceding Chevalier Jackson. You know, he had many great accomplishments, but what was his real innovation? I mean, like, you know, what did he really add to this progression of incremental improvements? He is credited with adapting light carrier technology for use with endoscopes that he developed, and he basically used an already patented light carrier from a cystoscope and applied it to esophagoscopy. As we mentioned, he really is the inventor of the lighted laryngoscope and bronchoscope, and he was involved quite a bit in esophageal dilation, and was one of the early practitioners of dilating the esophagus. Can anyone think why people of his time needed esophageal, especially children, needed esophageal dilation over and over, other than Dr. Pine? There we go, Basil.
Off congestion.
Yes, and lye in particular. So this was a big problem at his time that we occasionally still see today. And so I think it's important to realize that his success and his accomplishments really depended on the era that he lived in and his adoption of technology of the time. It's interesting to think about the pathology he faced. It's different than what we faced. He was dealing with the laryngeal manifestations of diphtheria, tuberculosis, and of course airway foreign bodies and esophageal foreign bodies and caustic congestions. The technology of his time was, you know, really revolved around the dawn of electricity, which allowed for the development of better lighting sources and the beginnings of anesthesia. A lot of these early procedures, you know, his were without anesthesia, which in itself is, you know, fairly remarkable. So what are the lessons for innovation today? Well, we could say Chevalier Jackson lived in the golden age of electricity and maybe the dawn of anesthesia. You know, what age are we in? I mean, it's quite advanced from that, but, you know, one might say we're in the information age or the computer age, or maybe that's already come and passed. Patrick Soon-Chiang, a well-known doctor and businessman, have basically labeled us as being in the cognitive age, in which we are now combining the collective promise of science, technology, and communications. And I think it's important to realize that in this period of time, you know, there's a gigantic change in how people learn. You know, we're blessed and lucky enough to have instant, up-to-date information at all times. That's a tremendous change. But we have to realize that the amount of new technical information in the world is doubling at an amazing rate, and we have to sort of keep track of that and harness that too. The rate at which didactic teaching goes out of date is also ever increasing. And so it's worth thinking about what exactly should we be teaching, you know, people and the residents of today. They learn differently, and also everything's just going out of date so much quicker than it used to. But you know, as people think about how we do that, I think they realize that it's important to think more about problem solving, about tackling, or coming up with new solutions for things, and sort of those skills as well as our operative skills. But probably we need a lot less emphasis on just rote memorization of data. I mean, that stuff's at our fingertips, and it goes out of date too fast. So what is innovation? You know, obviously, I think we're making the case it's important in medicine and ENT in particular. It can be hard to define though, and it depends on your perspective. Are you in business? Are you in medicine? Here's a few definitions from a business article, which I thought was interesting. They looked at they polled 15 key leaders in innovation. The application of ideas that are novel and useful. Here's another one. Creativity is thinking of something new. Innovation is the implementation of something new. So maybe not just an idea, but you know, you have to make it happen. Something new or different that delivers value to the world, with the key criteria that I'm not innovating if I'm not bettering people's lives. Put simply, it is the future delivered. And I think, you know, I underlined some key words there: novel, useful, and implementation, you know, just to give a sense for sort of the broader definition of innovation beyond just invention or an idea. Why is innovation important to us from more of a medical perspective? Well, we're into helping people and relieving pain and suffering and taking care of people, and perhaps less of a monetary motive in most cases. We're heavily interested and invested in quality improvement. Brian talked a little bit about cost. I mean, U.S. healthcare spending is over $3.5 trillion annually, 10,000 plus per person, and it continues to grow at about 4% annually. It was in the hundreds per person, 50 years ago. We might want to control costs. And obviously it's going to require some innovative approaches to do that. A lot of innovations are not about making money, but about saving money and being more efficient. It's important to solve challenging problems in medicine, of course, and as otolaryngologists, the reason innovation is important to us is because we bring a wealth of practical clinical knowledge and experience to the table. I think everybody should really not underestimate, the value and importance of just your record of clinical experience. Engineers, venture capitalists, technology transfer offices, anyone who might be involved in the pathway, bringing something new and innovative to a practical end or a market does not have any of that experience that you have, and they're never going to have it. That's what you get by grinding it out every day, and it's super valuable, and no one else has it, so just remember that. What are some innovations we could come up with? It isn't always medical and surgical devices, though that's what comes to mind first. It might be a new procedure, a new therapeutic, a novel approach to preventative care. There's some cool new diagnostic tests out there, and obviously monitoring when people talk about wearables and medicine and things like that. Maybe very useful in helping people and also reducing costs and improving access. And of course, there's always room for improvement in efficiency of healthcare delivery. Some of these things are more operational, but still very important. ENT really is at the forefront. You can see here among different categories of medical devices, ENT is among the top in terms of annual growth rate as far as new things coming along. And I'd like to make the case for a little bit why I think ENT is really the natural field for innovation. It's the specialty of putting ophthalmology aside for a second, it's the specialty of the five senses, right? We have a special understanding of how we as humans interact with our world. We are involved daily with a wide array of anatomy and physiology. We have a very diverse patient population. We always talk about how our field is a combination of medicine and surgery, and that's really true. There isn't, for the most part, a medical otolaryngology field that we just feed surgeries off. We're different from other surgical specialties in that regard. We do it both. We know what's going on, and then we take care of it. We're really taking care of both in that regard. And we have a lot of cross-discipline interactions with other fields. We're really involved with all of the other fields in the hospital. I think that this kind of background and these characteristics of ENT helped me a lot, in trying to come up with, some contributions, of my own. At least I hope some things that might prove to be helpful one day. And I'll talk to you about a few of them. This is one that I've talked about here at UTMB before, but the idea was to develop a 3D printed model for use in surgical training of the temporal bone, and also that perhaps has some usefulness as a preoperative surgical simulation for specific patients. And so when I came to UTMB first and talked about this, we're really in the early stages of it. But now our model is based on micro CT, and we've really improved the materials that we use with the help of some colleagues in engineering over at NC State who've helped us improve the likeness to drilling of human or cadaveric bone and that kind of thing. And so there you can see kind of the anatomy of our 3D printed model on the right. And I think it's making some big improvements. We obviously had a few papers published on that, and we're able to evaluate it with a face validity study. And this second paper here is a write-up of our work in developing a specific pediatric model for an individual patient, which we used for an actual case. our team met, we developed a model, had the bone printed, and met the night before, and everyone on the team drilled this model preoperatively to get a sense for, the unique anatomy that we were going to face. And this child had a number of mastoidectomies, including canal wall down already, and so I think it was helpful and kind of it helps to avoid pitfalls and probably some risks. So you can see the comparison there intraoperatively with the 3D printed model preoperatively, and I think you can see some of the similarities there. What has this led to? These days I'm not really competing so much with the other people who've been working on this project, around North America, but we're all cooperating now. We meet at Academy meeting and other meetings, and we formed a 3D temporal bone printing working group so that we're all trying to just come up with the best possible model, and both virtual and the physical printed model, in hopes of this being a resource to our field and our trainees nationally. I think we'll eventually have a library of unique models that people can download and print themselves. We'll have recommendations on how to do that, and the best recommended printer and material and things like that. And it's possible this would lead to some type of standardized testing down the road in a way that you really couldn't do with cadavers. I'll talk briefly about this one, but just another idea I worked on, maybe from a little bit more of a commercial or standpoint, with some commercial potential. But this was an idea I had for an adapter, very simple adapter to the iPhone, and it worked with a free app at the iTunes store, which is still there. The idea was just to allow people to use their iPhone as an otoscope. And this is a very simple device. So what we found early on was this probably does not appeal much to otolaryngologists, but it actually is not a bad screening device, and it appeals quite a bit to moms and families and people in developing countries or on medical mission trips, and even some of our primary care colleagues. And so we're a bit on hold with this one, just as I had focused this on the iPhone, and every time a new iPhone came out, I had to develop a new model. And so I was spending a lot of time learning about how things get made out of plastic and making molds and things like that, which was fun. But I think it's really due for a redesign that fits like every phone and fits over the case and things like that we received some feedback on. So I'll keep you updated on that one. But, and then over the last year or two, I've been working on ways to apply the emerging technology of augmented reality in our field to otolaryngology. And so I thought, it would probably be pretty cool if we didn't just have two-dimensional image guidance, but maybe three-dimensional image guidance that was overlaid on our patient and highly accurate. And so I kind of heard about augmented reality, and I didn't really know what that was, so I investigated that a little bit. And I thought, maybe this is the kind of thing that would not only show us a tumor that we're, can't necessarily see without the aid of such imaging, but maybe some of the normal vasculature, normal nerves, things that you can protect as well, and maybe even used endoscopically. Just sort of an illustration of what this might be. And so UNC was nice enough to give me a little bit of funding through an Innovation Pilot Award from our Center for Health Innovation, and I teamed up with our computer science department, and we worked to develop an AR system for both open and endoscopic surgery. And the idea was to allow for accurate localization of an area of interest, like a tumor or an abscess or something like that, some pathology, and also normal anatomic landmarks. And we also thought that it would be neat, if you are wearing a device and using it for three-dimensional image guidance, but you could also virtually place things around the room in your virtual environment, like X-rays, patient data, vital signs, maybe even a video consultation and things like that. Actually, all of that was the easy part. The hard part was accurate localization of our image. And so we developed this model. I made this all in the basement of my house. But there's an airway, thyroid, there's two tumors. Those are vitamin capsules and fish oil capsules that show up really well on CT. And there's a nerve in the back, a recurrent laryngeal nerve, and some carotid arteries. And so we made this physical model, scanned it, and uploaded this to a CAD application, in which we're able to make a virtual model. And then where the computer science folks really helped me was in achieving a very accurate registration. And so this shows the view as if you were looking through a augmented reality platform. In this case, it's the HoloLens from Microsoft, which maybe some of you are familiar with. And our accuracy was within 2 to 3 millimeters. There's certainly room for improvement there, but not too bad. Some of you know Bill Shockley from UNC. Here's Dr. Shockley going through our face validity study, in which we gave the surgeons a task to not only evaluate the system, but also to test their time and speed and see their ability to sort of find an object with the assistance of an augmented reality system. And there's a lot of neat features to it too. You can turn structures on and off with your voice by giving the HoloLens voice commands. You know, you can kind of dim this field, make it really bright, or kind of fade it so that you can see the normal structures. Certainly there's a long way to go in improving this and adapting it to routine use in the OR, but I think it holds a lot of promise. I mean, I think when people think down the road, you know, I don't think we're going to continue to use just two-dimensional image guidance forever. I think there's a role for three-dimensional image guidance at some point. And so I want to talk a little bit about, you know, what kind of environment sort of helps to foster innovation. You know, there's sort of yourself, right? You want to think differently, you know, to reflect on the Apple slogan. You know, you want to be curious. You know, it's this sort of, your why is what drives you in this regard, okay? And I think it's really important to look outside of your field for new ideas. You know, look at the technologies of your time. How do they apply to medicine? How do they apply to ENT? Time is a real problem. I put up a little video to the left here, a YouTube video by Rory Vaden on how to multiply your time, which I think is sort of a fun video to watch. But, you know, he covers the basics, but you need to remember them. There's certain things you just have to say no to if you're going to have time for certain things. And so saying no, taking things off your list is actually quite important. Things that you can automate are very important, and then you need to learn how to delegate too. So I think it's a fun video to look at, just to think about how do you get time for these things. I put the word empathy up there, not in the context of like your patients and their suffering, but a little bit more for when thinking about your colleagues and the people that are going to embark on these kind of efforts with you. You need to be a little bit sensitive to their needs. You know, if you'd like some time and money from your chairman, you need to think about where he's coming from and you know, what sort of helps him achieve the things that he's trying to accomplish too. The same for the students that might help you and colleagues in other departments. A good friend of mine, Shubhanoy Das, has talked a lot about making sure you establish win-win relationships, you know, when you're embarking on some type of effort like this. You know, everybody's got to kind of, you know, get something out of it that's helpful to them. You know, you won't be doing these things alone. I mean, I don't know much about computer science or engineering, so you know, you really have to enlist the help of colleagues. Do not be deterred, obviously, you know, stick with it. I put a picture of Admiral William McRaven there because a lot of these fall on his list of top 10 life lessons, and that's a good one to look up to. And then another Simon Sinek ism would be to play the infinite game. You know, this isn't about kind of doing better than someone else in the short run or winning. You know, the idea here is really to avoid those sort of artificial time constraints, and to in the business world, I guess it would be like quarterly reports. I mean, you need to look beyond that. I think a good example was I was in the temporal bone lab with one of our early models, and someone that we had in there doing our face validity study just couldn't let it go that this was nothing like a human temporal bone. And I thought, well, that's true. You know, our very first 3D printed model was not much like the human temporal bone evolved over 200,000 years. It was true. But, you know, I think what they were kind of missing was, you know, this is the beginning. There's going to be incremental change to this, and, you know, you have to kind of have a vision for, you know, where this is headed. So, you know, that's probably, I think, what Simon Sinek's talking about when he talks about the infinite game. It's not like about winning that year. Obviously, it's important. In white, I highlighted things that I think are kind of the environment around you. So, you know, how to create an environment that's supportive for innovators. And you want an environment where it's okay to fail, right? I mean, if you fail and no one ever funds you again, I mean, you know, I guess you're out. But that's, obviously, we know we learn from our failures, and so it's important to have an okay to fail environment. This is described well in the book Startup Nation, as far as the things that make innovative efforts in Israel so successful. Basically, they just keep funding the companies that fail. In short, you know, support for research is very important. Our academies and societies are very generous and have a lot of funding opportunities, and it's important to look into those. I think we should look at our own sort of goals as we think about our tripartite mission. How is it allocated? Is there too much emphasis in one area? Or if we set our priorities, are we really sticking to those priorities? You know, I may get Dr. Resto to comment on this later, but in some ways, you know, there can be a penalty for being involved in research. You know, there are caps on your salary for, you know, for the amount of support that you can use for salary. And so, in a sense, there's some impediment to research funding and efforts there. Diversity is really important, and not just, you know, and this is in the broadest sense, but it's not only the right thing, but it also is very important in terms of increasing productivity and increasing creativity, and there's many studies that show that. What are the challenges to innovation? Well, not enough time, and we talked about financial resources. We touched on this a little bit in the earlier talk, but the current fee-for-service healthcare model may be an impediment to the kind of time we have available to be involved in innovative efforts. You know, losing stakeholders is something to think about. You know, if you develop Uber, there's going to be a lot of taxi drivers that are going to be resistant, you know, to the things that you're trying to do. You know, how that's handled is an interesting question, but you know, how one handles progress. You know, I think it's good to look back on sort of our, I guess you could call it failures or maybe somewhat misguided efforts in terms of innovation. I put up balloon catheter sinuplasty not because the balloon is not a useful tool at times, but it feels like the real innovation there became the payment model, not so much, you know, a useful tool that was somewhat innovative. And I think that's something to watch out for. You know, an innovative payment model that doesn't necessarily serve patients or our field for the best, you know, would be something to kind of watch out for. Access to literature, I just put up quickly because it's becoming an important thing in our institution, and I hope you guys will keep an eye on this too, but they have dramatically limited the amount of journals that our library subscribes to. It's very important that we all have, you know, we have this unbelievable internet that connects us all around the world. They didn't have that in 1850, but we don't want to put a whole bunch of brakes on it and limit our access to each other's ideas and research results. And so I hope everybody will keep an eye on your library and what they're making available to you. You know, ResearchGate is a way to sort of share information, but you know, there's copyright issues there, but this is an important issue. And then there's going to be general opposition to anything new that you do. I mean, if you embark on kind of a unique idea that challenges the way things have been done for a long time, you're going to face some criticism, you know, some roadblocks, some setbacks, maybe even some ridicule, but you're probably just onto something. So I would hang in there. I'll go through this quickly. The first thing is just, you know, how do you get an idea? In my business school class, we sort of found that we're in like two groups. There's people that cannot think of any ideas for new stuff. And then there's people who have so many ideas they can't possibly narrow it down to a few things to actually focus on and work on. But, you know, I think you got to think about, you know, what are people's pain points, you know, what's in the world, and you know this from your clinical experience. I think it is important to think early on, like, you know, what is going to be the value of what you're doing? And so it is worth to think about the size of a possible market for what you're working on. You know, if you're looking to do something innovative, and so in that regard, you want the overall cost to society of the problem, you know, to be greater than the development cost of what you're talking about doing. Otherwise, this is not likely to kind of make it to fruition. And then I think, you know, in terms of reaching creative solutions, it is important to look at other fields and new technologies of our time. You know, I've listed a few on the left there. Artificial intelligence, you know, these are sort of some of the big things that are out there right now, and one wonders, like, how can we sort of apply some of these new things to our field? Machine learning is an interesting subset of artificial intelligence in which algorithms are used with big data sets to sort of teach machines to interpret things. For example, applications in our field have been using machine algorithms to interpret tympanic membrane images. And I saw a talk actually at COSM this year about how much more accurate the machine algorithms are, not only than the primary care provider, but than us in interpreting tympanic membrane images over time. A subset of that is deep learning. I think deep is a good buzzword right now. If you want to use that, I'm thinking of coining deep otolaryngology. It sounds mysterious, innovative. But there is a field called deep learning within machine learning. Big data really just means huge data sets. I think it's important, enormous data sets, Amazon, Facebook kind of data sets. And we're generating that too with every click, right? So who's going to use all that data, for something good, and something innovative in medicine and ENT? Hopefully it will be us. But it's important to realize that just because it's a big data set doesn't mean the old rules of statistics and bias don't apply. There's been some famous failures in big data. Google's influenza trends, one comes to mind, but you can look those up. I talked a little bit about augmented reality. CRISPR is one that I'm not super familiar with, but appears to be a very revolutionary gene editing tool. And I think telemedicine is going to have a big impact on our future in terms of reducing costs and improving access. When you have a device or a new innovation, it's good to learn about the classes of FDA approval that you might deal with. They have a little bit to do with how invasive something you're working on might be. And a 510K approval is basically an exemption. If you've come up with something that is close to or similar to something already approved and in use, so that's an important thing to know about and used a lot for approval. When it comes to intellectual property, the whole world, in my opinion, doesn't revolve around patents. Now you're at UTMB, and I think if you had a great idea, there are amazing resources here. The Office of Technology Transfer would be one that you'd want to communicate with, and they'd help you do a report of invention. They might help you do a provisional patent filing, and ultimately help you with a patent, and they might find licensing opportunities for your new technology. So these are some good things to learn about, but there are other ways to protect ideas that you're working on. It might be copyrights for some software. It might be just trade secrets that you're not necessarily revealing. And it is good to remember, if you think something has some commercial potential, that doesn't mean it's not a good idea for humanity, but things may have commercial potential. Once you present it at a meeting, it loses its ability to be patented and protected. So if you have something like that, you want to talk to your Office of Technology Transfer before you go put up your poster or present it at a meeting. That's very important. And then lastly, if you have something that may have some commercial potential, the office will talk to you about possibly forming a company, and they'll get into things like the team that you employ and raising money and things like that. So I talked to Harold a little bit about an idea that I had when I was dabbling with applying to be chair at UNC. I was sort of honored just to be in the application pool, but one of the ideas I had at the time was we should have a grand effort that involves everyone's individual talents in kind of one big project that moves something major forward in ENT. And so the idea was kind of an ENT moonshot. There's the moonshot, which everybody's familiar with here in Houston. There's the cancer moonshot from the NIH. I think their logo is kind of lame, but I'm going to get Harold and maybe Jason to help with designing a logo for the ENT moonshot, and maybe it's something we can cooperate on, not only across institutions with our sister society here at UTMB. So I did a little poll of you all just prior to the talk to see what you thought might be some needs in ENT, for us or for our patients. I'll read a few of them, but some of them are really great. The first is less cords. Why are there so many cords everywhere? I knew exactly that. Okay, I think that's really good. I think things need to be more cordless in the OR. More videos of surgery, especially head and neck cases. Point of care labs for parathyroid testing and beta-2 transferrin. More patient-friendly and effective nasal packing for epistaxis events. Standardized portable adapters and video options for recording endoscopy. How to fix a blocked ear tube, something we all deal with on occasion. How to better assess the benchmarks and real salary of otolaryngologists. Very interesting. You have to pay a lot of money to get that data currently. And how to develop a digital textbook of otolaryngology. which is something that has probably been pioneered more here at UTMB than anywhere else. But the underlying part is that it updates itself. Pretty amazing. I think that's really a remarkable idea. I mean, who was able to read all of the literature in ENT last year? I wasn't. I mean, you know, we need help with that. We need, probably the best way to curate that is some type of machine learning algorithm that knows how to do that and help you with that. And so I think that's a really remarkable idea and probably the future. So I'll conclude here. I think that there's going to be a lot of change over the next 20 to 30 years in medicine, in how we take care of patients. And I think that we're uniquely suited as otolaryngologists to be at the forefront of that. And it's important that we do and make sure that that as these changes happen, you know, they reflect our values, they serve to benefit our field, our trainees, our students and residents, and most importantly, our patients, right? I think that we might want to consider including innovation as the fourth pillar of our mission, along with patient care, research, and teaching. And it sort of overlaps nicely in each of those areas. And I tried to make a couple points today. One is that I think ENT is uniquely suited as the natural field for innovation in medicine. And that innovation in ENT is critically important. We really need great people to, you know, sort of match the amazing research discoveries that are being made. Obviously you have great people here at UTMB. It's been a pleasure to be a part of it. Thank you for having me. If there be questions, close to over my time.
You know, it's not really a question. Thank you, Austin. That was great. I'm going to offer a comment, and in a way it's going to integrate some of what Brian shared with us a little bit earlier. I think innovation, you know, to talk a little bit about your diagram, I think innovation is something that's fundamental to every one of each of those areas. I don't know that I would call it a pillar independently, but it's really sort of a fundamental piece of each. Innovation of patient care. Innovation, you know, is really the finding of research.
Can't hear you. Can't hear you.
Innovation is clearly important in education, you know, as we have changed how we teach. We see this over and over. I'm going to throw in there that perhaps the fourth area that requires some significant work and thought, not only innovation, but implementation. It really has to do with how we pay for every one of these things. It is really an independent problem. You can come up with the most amazing evolution of your surgical technique, and at the end of the day, if it cannot be paid for, it will not come to fruition. You can do research or not based on similar issues. How we teach is increasingly, you know, being taxed and squeezed, you know, by how we pay for things. And there's now, you know, a fundamental science behind, you know, the business of medicine, the economics of medicine, you know, that function all the way from a local setting to really a population-based setting, you know, and I don't know that we embrace it, you know, as a field as openly as we should, but I think that as we evolve and medicine evolves, the kind of surplus that existed broadly, where really it really wasn't at the forefront of thinking because there was always some left over somewhere to do things with. It's just not true.
I mean, I think that's completely true, and Brian touched on that as well. And obviously, a lot of innovations are about cost savings and efficiency, but probably all innovations should, you know, we should be trained to include that as part of our thought process when we're developing something. And, you know, how is this going to be?
But I didn't consider it separate because you want your educators innovating in terms of how they can educate better. Do they need to sort of lose a lot of their energy in figuring out how they're going to pay for it as well? Some, because they'll be experts at it. But I really think that this fundamental sort of fourth circle of the people who think about how we bring all this together, they recognize the value, but sort of divest a creative force, you know, into how we're going to put this together economically.
Awesome.
So a little bit to dovetail on that, I think one of the takeaways from your lecture is that it's very important to understand who our partners are in any of the ventures, whether it's patient care, research, education, paying for stuff. And, you know, it's a marriage of sorts, and it can be ugly or it can be productive, or somewhere in between. When you talked about, you know, using the office technology, for example, there was a recent talk at ARO, panel discussion on innovation and how to get started. Yes, using your office of technology could be very good, but remember, they're your partners and then they're part owners. If they decide they want to move forward with the project with you, you may be tethered by that. As a young innovator, you can use their resources to help further your goals, but sometimes at some point your goals and the institution's goals aren't going to be the same thing. You may then need to make that difficult decision to break away and go on your own. But again, choosing your partners is very important. Dovetailing about what Dr. Ressa just said in terms of paying for research, and for me, the interesting is paying for education. We have residents that we need to educate, yet the residents are always sort of, for years, since residency has begun, we sort of live a split personality. You're not only employees of the hospitals or required to provide service, but you're also there to learn, and so there's an educational component. And I think increasingly, the burden has been pushed from the hospitals onto the academic departments to say, well, that's your problem, they're your residents, when they really are the hospital's residents. And there needs to be some sort of shared cost or understanding that, yes, there is a cost of educating, and the cost of not educating our residents is that we don't graduate the next generation of caregivers. So it's a difficult situation, and you're right, because you have to figure out how to pay for it, but I think sometimes the microscope is always put on our departments or just the practitioners, just like Dr. McKinnon said, no, it's the doctor's fault why healthcare costs are. No, it's not just the doctor's fault. It's a global problem where everyone has a stake in it. And unless we understand who our partners are and how we deal with those stakeholders, we're going to fail.
Yeah, all great points. I mean, and I really touched only briefly on, you know, intellectual property and how you handle that kind of thing, and obviously even less on capital raising and dilution of equity and all things like that. But these are the, you know, important but topic, you know, whole talk kind of topics. Right.
In hearing this conversation, I wanted to point out something that my research has availed to me. We had mentioned earlier that less than half of hospitals are profitable. The hospitals that tend to be profitable are the academic teaching facilities. It's the hospitals that are not academic teaching facilities that tend not to be profitable. There's something in our academic model that is not well defined that actually makes us better stewards of our resources, as odd as it may seem, than many of the private community hospitals that do not have academic training programs. So the discussion here is important, but we actually may be in a better spot than we may realize when we look at healthcare delivery as a whole, that as academicians, we actually do a better job in managing the stewards of the resources that we have. And I think we do have the ability of looking into our own resources. As I pointed out earlier, a third of healthcare costs are administrative. If I could cut my administrative costs from 30% to 20%, I know what 10% to do something else with, which would be reinvestment. If you look at companies, private companies that are successful, they recognize by reducing their administrative costs, they can invest in R&D. And most companies realize that R&D is far more important than administration. And R&D for us, of course, is resident education. It's just a question of looking at our own institutions and figuring out how can we do a better job at managing the resources so we can say this is the priority. Physicians have a huge role because we're the ones that apathetically and understand the process of healthcare better than probably anybody else in the institution in their respect. I start a question with it.
So you think it's the resident model maybe that also contributes to profitability? Maybe more cost labor?
It's an interesting question. So what I will tell you is it may not be the residents per se, but the fact that residents challenge the attendance of the care. When I'm in academic practice, it takes me an hour, it takes me 2.5 hours to do a private practice, it takes me an hour to come. You are not cheap
In the open,
in the open.
elsewhere.
In the clinic, I have to teach you. That's my obligation. So it's gonna take longer with the patient than if I don't have it. Right? So there is a cost associated with training the residents. Are there facilitations? Absolutely correct. But it's not a huge savings. But what you do force us to do as attendants is to think much harder and to behave differently. And because we have to be responsible